and cut from there.
So this is a 17-year-old male presenting to emergency department with chest pain. He had a fairly undifferentiated past medical history. So there's a history of congenital heart disease where he had a sternotomy scar and surgical repair at age 2, but we didn't really have any other details through family, the patient, or any like surgical notes that were available. He was just on aspirin daily, and he emigrated from the Congo to Canada 3 months ago. We didn't have any other surgical scars. He came in with this fairly non-specific chest pain, and when the emergency physicians listened to him, they heard a very loud murmur, systolic murmur, but they also heard other murmurs throughout. So given his undifferentiated presentation, we were kind of asked to do a stat echo in the emergency department to try to figure out what was going on. And so just for those who may have not heard in the past, we'll just get people to shout out or put into the chat if you see kind of any abnormalities that you want to comment on. Starting with our person along here. Peg has also kind of commented on that echo, exactly right there on the screen. Echo bright structure, just inferior to the aortic valve.
Coronary stenosis,
slightly prominent, yeah.
Yeah. So it's just suggestive of previous surgery. I remember this BSD area.
Yeah, the root/sinuses do look a little bit prominent as well.
See, this is why somebody called it subaortic membrane. There's a little projection.
Yeah, there's something funny.
Yeah, whether that's an artifact from the patch or something else.
I think the patch being pushed down by every contraction. It looks like.
Yeah, it looks like the flow across the aorta is okay.
Yeah, no, there's nothing across the interventricular septum.
But as mentioned in the RVOT there, and kind of this limited view, we do see some turbulence.
Systolic, looks like.
The outflow, yeah.
We're looking at pulmonic valve.
Stoning.
So very nice to
Excellent sonographer, whoever that was. What's that? Wasn't good enough to get that. What's that?
Color.
We did do color. Yeah. Yeah.
There's another abnormal flow here, which looks continuous-ish. Is it? Yeah.
Just at least you see median diastole. Systole is the fourth flow that's kind of masking it.
We can go back here. Looking at the leaflets here. A couple of views like this. So continuous flow consistent with possible PDA, but there's lots of flow acceleration as well. So there's two kind of things we're looking at. Pulmonary regurgitation as well across the valve there. Again, we're seeing kind of flow acceleration out the RVOT.
It's interesting that when you look at the pulmonary regurgitation flow, it seems really high in the PA. But when you have that zoom view, you get the sense that the leaflets were actually pulled up into the PA a little bit. So it probably is at the coaptation point of the pulmonary cusps. But when I first saw it, it was like that's a little bit higher than what I think the Adams is.
This is a CW through the PW, yeah. Thank you.
So definitely the flow is higher than what we would expect.
Yeah.
Usually it's 1.
CW
or less.
CW. This
definitely higher.
7.
You can see the mean and max gradients there to the left-hand side of the screen.
It's 2017. Looking at the PDA again.
Mm-hmm.
So online colleagues are correct. I don't know what F4 is.
It's now just going to the tricuspid valve. Yes, we see some kind of trace TR. Incomplete Doppler profile just because of the trace TR, but RVSP is at least kind of 29-ish. So your short axis. Anything on short axis here that gives us any new information or something we may have saw in the parasternal long?
It's a vertical line there. So the left atrial side.
It's like there's an aneurysm in the right RCA.
Yeah, there's something funny around that.
There's something funny there, which is where we also see the echo bright area, which, yeah, exactly right there. I think the next one's zoomed in. No, it's not. Never mind. Let's go back. Which is right near where we saw that's essentially a possible patch repair. We can see the pulmonary leaflets again quite nicely. These few look like they're opening pretty good, thin, kind of pliable, opening well.
Bunches.
Short axis. So like just more trabeculation on the right side. It might be a moderator band. See, when we're looking at the apex, like the size almost looks kind of same. So that maybe gives you some early indication that there is some RV dilation. Okay, so this is another view of the.
Very nice picture.
Anything else with the valve, like just inferior to the valve, subpulmonic? You're kind of wondering about this echo bright structure here.
I labeled MPA.
Because as we saw, there's flow acceleration across that area, but in our last couple of images, you can see that the leaflets themselves are fairly pliable and opening okay. So it doesn't look like there's significant leaflet restriction, but there is kind of this echo bright density just under the valve. We can see that in this view, I thought it was decent that the flow acceleration is not occurring like right at the valve. Looks like it may be occurring just before. So your fourth chamber here. The basal dimension of the RV is about 4.1, 4.2. So
The left heart looks bigger than that left heart.
yeah, so it looks a bit dilated.
I think it's a small left heart, this young man.
More of an RV specific view. There's kind of like lots of trabeculations. It's hard to tell if there's actual hypertrophy, I thought. There's trabeculations. So 3-chamber view again showing normal flow across the mitral and the aortic. This is more of an off-axis view. I appreciate the basal dimension of the RV is a bit generous.
And also the ECG is abnormal as well. The QRS is widened.
Yeah.
So it's likely, I'm just guessing it's most likely some kind of bundle branch block and most likely right bundle in this case.
Yeah, exactly. More of like it was actually like a bit of an atypical right bundle, consistent with bundle branch / potential a bit of RVH as well, contributing. The subcostal view. This is just another view of the outflow. See PDA as well as flow acceleration. And then this is our aortic arch. You can see normal kind of arch anatomy, brachiocephalic coming off.
So most likely a left-sided arch.
And then we see more so continuous flow in this area here, which is consistent with kind of the PDA that we saw in other views. And this is the PW at the aortic arch.
At the PDA.
At this side of the PDA, yeah. Yeah.
continuous.
So essentially that's where we're seeing our continuous flow. There's kind of augmentation during just after systole, and then throughout diastole, we see this continuous flow here. Okay, and then because the right heart was a bit dilated, we decided to use some bubbles. Positive, negative.
It's not
Dr. Howard, specialty.
Kind of looks like a puff sign.
Looks like a puff sign, I agree. Yeah. Crazy you're saying early? Yeah, 3-ish cycles. Yeah, exactly.
And it's, we'll see the origin.
Yeah, and you can see it actually a bit better here. Valsalva.
Actually useful to slow it down and go frame by frame if you want to.
Yeah. I'll try actually, because we did that.
See if you can see it actually come across there, right there.
nice.
You sometimes miss that if you leave it in real time. It goes too fast. Nice.
Okay. Summary. Okay, so overall, this was our interpretation. Happy to hear other people's thoughts and stuff. But the left ventricle ended up being borderline dilated on contrast enhanced images. We did do contrast after the bubble. We thought that the echobright density was consistent with probably a perimembranous VSD repair. The systolic function was normal wall motion, normal diastolic function. Right ventricle was mildly dilated, again in the 4.2 kind of basal dimensions. Low normal systolic function, the TAPSI and the RS prime were kind of borderline in the 1.8-ish area, 9-ish area. Agree with the agitated saline. We thought that there was 2+ bubbles. It was early within 3 cardiac cycles. You could see it directly coming across the kind of middle of the intraatrial septum there. So we thought this was most consistent with the PFO. RBSP was around 32, but could have been underestimated just because of the incomplete Doppler profile. Now, regarding the pulmonary valve in the PDA, so we can see some color flow acceleration across the pulmonary valve. We were wondering if that linear kind of echo-bright structure just inferior to the pulmonary valve may have been like a prior repair, stitch, membrane, something like that. And we could see some flow acceleration occurring just before the pulmonary valve, and we actually saw the leaflets opening quite well. So we were wondering if this was more so consistent with kind of subpulmonic or infundibular stenosis. It ended up being in the mild range, and we'll talk about pulmonary stenosis briefly. PDA was visualized with continuous flow. It looked pretty prominent. We could see the continuous flow in the aortic arch as well. Regarding that defect in the aortic on the short axis of the aorta, differential would be kind of small sinus of Valsalva aneurysm versus just a bit of outpouching where that patch was essentially placed. But no flow across that area, no kind of structural degeneration of the aortic valve at all. And so we thought, taking in everything in consideration with his sternotomy, age 2, we thought that this was probably most consistent with prior tetralogy of Fallot, with VSD, pulmonic stenosis that was repaired. And he has some mild residual subpulmonic stenosis and associated PDA. We did also think, because that AVSD could be on the differential as well with a couple of other associated congenital abnormalities, but because of the PFO, it would be unlikely that they repaired around, like open surgical repair around the AVSD, like they were putting that together and then left a PFO or a PFO was fixed. So we thought it was probably most consistent with tetralogy of Fallot. So just in general, when we're dealing with undifferentiated congenital heart disease, I found this approach through my cardiology training useful, just to kind of separate the 4 individual parts and just have a framework when you're looking at an echocardiogram. And so the segmental approach is that you essentially look at sidus and cardiac position. Then you look at the atrial chambers, the AV junctions, so the 2 valves, and then you look at the ventricles and the arterial trunks, and then you try to kind of put everything together to determine the patient's anatomy. From a sidus perspective, for congenital cardiology or undifferentiated congenital heart disease, you actually recommend just start in the subcostal because that will give you basically a gross kind of look at all of the four cardiac structures. You'll see the orientation of the heart. And most importantly, you'll see the orientation of the IVC and the aorta, because the IVC and the aorta are actually going to tell you the sinus of the patient. So for situs solidus, which is your normal anatomy, versus situs invertus, essentially you get switching or mirror image of all your thoraco-abdominal organs. So you can see on the side there that you get switching of the bronchi, the lung lobes, as well as all the intra-abdominal organs. And the way that we can look at this easily on echo is just look at where the IVC and the aorta is. And so it will be reversed in situs inversus, which will then follow the rest of your organs. And this is best seen in the subcostal view. When we think about cardiac position, levocardia is kind of your normal anatomy. Dextrocardia is that where the apex is now pointed to the right, and then mesocardia if it's essentially midline. And you can have every combination you can think of. It can be normal situs, but dextrocardia. It can be in situs inversus and dextrocardia. So there's a lot of different variations that you can see there throughout the four boxes. So kind of looking at them separately and then putting it together as opposed to trying to do all the combinations in your head can be an easy way or an easier way. Now, regarding the atrial chambers, this is kind of the next thing that you look at. And essentially, the way to distinguish the two atrial chambers is that you're going to be looking for the morphological characteristics that fit with each chamber. Some of these are a little bit more easy to see on like a transesophageal as opposed to a thoracic. But essentially, for the right atrium, you want to look for your venous inflow. So you're looking for your IVC, SVC, as well as identification of the coronary sinus, because that anatomy is all going to fit with the right atrium. And then you also look for all the embryological remnants if they are present. And those can be quite helpful to say, like, this is definitely the right atrium. So you're looking at your eustachian, Chiari, as well as your crystal terminalis. The appendage, usually we can't see on just a general transthoracic, but in general, the appendage is much more broad-based, whereas for the left atrium, it's more of like a windsock, finger-like kind of protrusion, as opposed to just a broad-based triangular appendage. And then the venous inflow with the pulmonary veins can be helpful for the left atrium, with the caveat that in people with congenital heart disease, they're more likely to have anomalous pulmonary veins, so that rule kind of may not always be followed. The AV junction is one of the things I find most helpful, because the AV junction is always going to follow the ventricle it's associated with. So the mitral valve is also always going to follow with the left ventricle, and the tricuspid valve is always going to follow with the right ventricle. So sometimes it's hard to tell the ventricles themselves because there may be dilation over time, kind of distortion of the anatomy, but the valves themselves will always follow the ventricles. So you look at the valves first. When we're looking at the tricuspid valve, probably the easiest thing is that the tricuspid valve in normal anatomy is going to be apically displaced. So there's going to be apical displacement of the tricuspid valve plane as opposed to the mitral valve. So this is a four-chamber here, and we're going to see that the tricuspid plane is essentially apically displaced compared to the mitral valve. And that's one of the most helpful things. If you see them on the same plane or aligned, that is consistent with possible AVSD spectrum disease, because they essentially have like a variation in AV valve. And so them being on the same plane is very characteristic of something abnormal, as opposed to the apical displacement, which really helps you determine that, yes, this is a tricuspid valve. Other things that are characteristic of the tricuspid valve is the leaflet, the number of leaflets you're seeing, but also where the cords attach. So for a tricuspid valve, there's a variety of chordae. They're attached to the kind of chordal apparatus, but the cords actually attach to the septum of the right ventricle, whereas for the left ventricle, you do not see them attached to the septum. They're always going to be attached to two discrete, or maybe, I guess there could be an anatomical variant, but ideally two discrete papillary muscles that are attached to the free wall. So they're not attached to the septum. So looking at the pap muscles, looking where the cords attach can also help you. Now, regarding the ventricles and the arterial trunk, so most of it, again, has to do with just the general anatomy of the two ventricles. So the RV, again, is usually apically displaced. It's more coarse trabeculations. You can see a moderator band. And then there is an infundibulum, so like a conus arteriosus, where there's a separation with the RVOT between the tricuspid as well as the pulmonary valves, which you can kind of see here. So there's more of like a outflow tract separation, muscular ridge between the tricuspid valve as well as the pulmonary, where in the mitral side, we see that there is the aortomitral curtain. So these are essentially continuous, or the aortomitral continuity, where the mitral valve as well as the aorta, there's not like a big separation or RVOT or muscular ridge or infundibulum, nothing like that. It's just essentially like a continuation. So those anatomical things can help you. And then when you're looking at the trunks themselves, the division into the two pulmonary arteries, as opposed to the aortic arch, where you'll see the subclavian, innominate, and left carotid. Now, when we're talking about pulmonary stenosis, in general, there's kind of an anatomical classification. So we see supravalvular, subvalvular, as well as valvular. For kind of cardiology, Royal College classic exam questions, supravalvular are typically associated with tetralogy of Fallot, Williams syndrome, and Noonan syndrome, whereas subvalvular are more characteristic of, again, tetralogy of Fallot, but you can also have them associated with a VSD or just isolated infundibular hypertrophy. VSD, you can get subvalvular, is depending on where the VSD is, you get very high turbulent flow that's essentially hitting the right ventricle, hitting the muscle bundle, which may be near the RVOT, and that causes hypertrophy, kind of like degeneration, and so that can cause essentially stenosis in the subvalvular area. When we talk about valvular, there's a couple of different anatomical classifications. So you can have thin, very pliable leaflets that just dome outwards, so they're restricted and they're opening, not necessarily because of the leaflet like thickening or anything, but they're doming outwards, whereas you can also have dysplastic leaflets which are thick and immobile. And an easy way to remember kind of severe stenosis or RVOT obstruction, it's actually the same velocity as the aortic valve. So greater than 3 meters per second is in keeping with severe stenosis or RVOT obstruction. The PDA is just, what's that? Greater than 4. Yeah, did I say 4? Oh, did I say 3? Sorry, greater than 4. Greater than 4 meters per second. For PDA, as most of us on the call know, it's an embryological remnant that allows for fetal, like partially oxygenated fetal circulation to go directly to the descending aorta in the baby's body. So essentially, these people can present in a variety of ways later in life, and it really depends on how long the PDA has been there and how significant the shunt is. And so in a small PDA, which doesn't have a lot of significant shunting, we hear a very loud, continuous murmur. It's loud because the pressure difference between the pulmonary system and the aortic system is high, and it's continuous because that pressure difference remains throughout systole and diastole. And so in someone with a small PDA, it's going to be a very loud machine-like murmur that's continuous. As the PDA progresses, or if it's increased in size, we hear a continuous murmur, but we also hear that it decreases in intensity over time as the pulmonary pressures climb, because that pressure gradient is now smaller. They also develop features that are similar to kind of aortic regurgitation because of enhanced flow to the left-sided system. So you can have an increased pulse pressure, bounding pulse, and that's because of essentially a similar physiology to aortic regurgitation, but that continuous diastolic flow is going to the pulmonary system and then translating to the left-sided systems. As this progresses and the patient develops significant LV dilation, pulmonary hypertension, you actually get absence of this continuous murmur, and that's because there's no longer continuous shunting because the pulmonary pressures are now being so high that they actually rival the systemic pressures. And so you get absence of that murmur because you don't have as much shunting. And so that is a very bad thing. And at its most kind of like terminal stage or kind of severe stage, you get Eisenmeyer's physiology where you actually get transient right to left shunting. And remember, that's going to be deoxygenated blood. So these patients have a very interesting physiology where their lower legs or their toes are blue and cyanotic and clubbed because you get asymmetric cyanosis to the lower extremities through right to left shunting through the PDA. And so essentially principles of echo evaluation is because it provides a volume overload to the left ventricle, which is, again, another classic kind of exam question. You think that it would overload the RV, but it's actually going into the pulmonary system and directly to the left ventricle. So you're volume overloading the left side. You're looking for chamber dilation as well as systolic dysfunction. QPQS shunting, if you're able to characterize that in echo, but again, some of these patients may have other congenital heart disease, RVOT obstruction, which makes this formula challenging. You're looking for signs of pulmonary hypertension. Similar to a VSD, we can actually calculate pulmonary hypertension through the peak velocity through the PDA if we subtract the systolic blood pressure, and then the classic kind of continuous diastolic flow in the ascending aorta. And so these are our classic views. We're looking at the ductal view, which is just a little bit off axis from your short axis view, and then your suprasternal view, which we both captured on our echo. Here. And this is our classic kind of sawtooth PW Doppler profile with continuous murmur, which is augmenting just after systole and then kind of remaining throughout diastole. In general, indications for closure is that device or catheter-based therapy is preferred over open surgical repair. Once you kind of start to develop any LV enlargement, or if there's a significant increase in stroke volume, which they kind of define as cardiac index and cardiac output, but also that you want to be able to show that there is a significant QPQS ratio of at least over 1.5, so a significant degree of shunting, and the patient hasn't developed pulmonary hypertension, that's kind of the ideal candidate for percutaneous closure. And so with simple anatomy, they're just able to go up into the pulmonary artery and just put a little plug there to essentially stop the flow. These high velocity shunts are also at risk for infective endocarditis as well over time, just because of similar to jet lesions, you get distortion of the endothelial lining just from the high velocity shunt. And so in a patient that develops an infective endocarditis, that's also an indication for closure. Once pulmonary hypertension develops, it becomes a little bit more complicated because closing that structure can cause problems with pulmonary circuit as well as the right ventricle. And so once they develop pulmonary hypertension, there's more of like an individual kind of patient decision. So overall, for this patient, he had kind of atypical chest pain. His troponins were negative. It was more so kind of MSK, but it's lucky that we got a comprehensive echo because with the PDA, the not clear pulmonary hypertension, but it looks large enough that it could cause some hemodynamically significant shunting, and he had borderline LV dilation. He was referred to our congenital colleagues down the streets for evaluation because this will need to be closed at some stage.
Thank you, Mike. So just very review, and just want to mention the repeat TED case, which is one of the most common congenital cyanotic disease that actually we still see that, and because in Canada we have a lot of immigrants, and then a lot of them actually got repaired and then come to see us, and then we have to image them, and then we figure these things out. It's a combination of overriding aorta, pulmonary stenosis, ventricular septal defect, and right ventricular hypertrophy. Of interest, the tetralogy of Fallot was initially described in 1671 by Danish researcher Niels Denson. So initially it was actually Danish, and then it was subsequently described again in 1888 by the French physician Etienne Louis Arthur Fallot, after whom it was ultimately named. And even more interestingly, coming back to the Canadian history, in 1924, Maud Elizabeth Seymour Evarts, who is actually a student of William Osler, pediatric cardiologist from Montreal McGill, named it tetralogy of Fallot. So the name of TOF actually comes back to Canada.